like this, you know something's up, or like that. But outside of that, in terms of the evaluation part, I'm going to do the evaluation of the occiput C1. So I tend to use my index finger for this evaluation, and I find the mastoid process, and then I find the transverse process of C1. And, so my finger is in there like this. The medial aspect of my index finger is on the mastoid process. The lateral aspect of my finger is on the transverse process of C1. What you're feeling for is that space that's in between there. Now this model doesn't have a mastoid process, but you can see just basically in relationship to the occiput that's here, that there's a spacing between the occiput and the transverse process of C1, right? So, if you imagine that this is a mastoid, you'll be able to put your finger in there and feel them. So you can feel both structures with one finger. Yeah. If you are not doing it or not feeling it, you're in the wrong place, or the person might frankly just have such a tight musculature structure that you can't feel it anyway. And not everybody's C1 transverse necessarily is significantly large enough to feel very easily. So I know that you'll find that, like this partner was really easy to palpate, this other partner is not. Also take into consideration the person's sternocleidomastoid muscle, right? Sternocleidomastoid, that insertion is over that structure. So if it's really tight and fibrotic and constricted, you will have difficulty getting through it to really feel, C1. So I usually do this first so I can palpate to see if, again, is it jammed, or is it gapped, or is it symmetrical. Now, understanding that there's going to be a variety of other possibilities, because, as we talked about in class, usually the side that is jammed is the tight side, right? So when it's tight, it makes things pull towards itself. So you might palpate a laterality. You can also potentially palpate, a rotation. So there's a number of different combinations, but I'm just going to really focus on it's jammed or it's gapped. But that's not the only potential thing you're going to find, but that's what I'm going to focus on. And once I kind of evaluate and establish what's going on with that, I can go down and palpate the rest of the cervical spine. And in doing that, I tend to use my middle finger because it's just longer. And then I'm feeling the facets. And again, what I'm feeling for is that, star, tart, rats, or rat in relationship to, is it sensitive, is it tender, does it have tissue texture abnormality, does it feel malposition, like there's a rotation, or does it feel like when I do the joint play stuff, does it feel fixated? Is that sensitive right in there? Yeah. So I can feel right here some gnarly stuff. So that's the word I like to use. It's not very medical, but it kind of gets, So that is an aspect of the static palpation. And then before I go on to the correction for occiput C1, just in terms of a review of what we did last week, if I want to check the lateral bending component, I could come up to, C1 occiput. I can find that transverse process of C1 again. Then what I can do is what's called ballottement. I can push it back and forth like this to see easy to push, hard to push. The hard to push is the one that's fixated. The easy to push is the one that's not. That's, I told you the story. So I'm pushing back and forth and seeing if one side again is restricted or not restricted on that particular segment. Also getting feedback from your patient, is this sensitive or not sensitive, and so on and so forth. And then I can go down lower to C2. And then again, I'm just pushing it laterally with my distal index. I did have a release down here, and that's kind of like, that's like low-lying fruit. And so one of two ways I like to use my thenar eminences, kind of holding the zygoma, which allows me to push laterally the one way or the other. I'm also can tell that the left side of her neck muscles are just tighter. She's more fibrotic and kind of tight on the side. Or I can kind of just rotate over here and use my hand and kind of push in laterally like this. There's another way to do it. Whatever you kind of feel. This is kind of like kindergarten level, and this is like doctor level. But I know you guys still kind of a kindergarten with palpation and stuff.
You mean it's like sort of a sneaky?
Yeah,
sneaky
you
thing.
eventually kind of turn into a snaky thing. And then to do rotation, I'm going to rotate the head. The hand is still in that comparable contact that we've learned all along. I'm going to use, again, my distal index finger, again, contacting the zygoma, and then I'm going to rotate the spine up. I'm going to feeling for rotation. The lower I go, the more I need to rotate it, right? Because the lower I go, the more that segment's going to rotate. So I'm just, again, feeling for joint play. Once I've made that determination, now I know it seems like it's locked here, or it's fixated there, or it's rotated here. So I've got or it's sensitive here. So I've made my determination, right, at that point. So I've done my diagnosis. I know what's kind of going on. Now at this point, I can do those things that we just did. to go in there and work out the trigger points, traction stuff, and once I run through that particular scenario, then I'm ready to do manipulation. And at this point, then the person's neck muscles are fairly relaxed. And they also are somewhat used to you palpating and their hands around their head and neck. So they're not going to be taken aback by just kind of coming up, boom, and coming on it cold and doing the big, correction. So they're a little bit used to you. So it helps that way for that context. So again, in palpating Dr. Marie, I did not find necessarily a jammer or gap necessarily. And interestingly enough, I know in the final exam, I'm going to ask you to palpate looking for a jammer or gap, and nobody's going to have one. It's like, oh no, my partner is fine today. So, that's fine. I'll just say, okay, we're going to make one up. All right. So, in this case, we're going to make it so that Marie has a left-sided jam. All right. So, in terms of doing the occiput C1, which is different than C1 through C7, the lesion side is going to be down. So the lesion side is down. I'm going to contact the upside C1. And so my line of drive is going to be through kind of the nose oral area, or maybe even the angle of the chin, just kind of this area here, depending upon what the right vector is. And so basically, by making that correction, I'm going to be gapping the jam. I'm going to be jamming the gap, which is going to gap the jam. So basically, I know that's a lot. Can you hold this up for me for a second, Marie? Yeah. So if she's like this, and this is the jam side, can you all kind of see that? So if I come in here to make this correction, I'm using C1 to make that happen. When I do the correction, it ends up kind of going like that, right? So then this other side is the side that opens up. And then it, again, theoretically releases, and then you have a reestablished normal pattern. Okay, so that's what I mean by, jamming the gap to gap the jam. Now that only happens at occiput C1. It doesn't happen anywhere else. So if it was left-sided, and again, in terms of your contact in the cradle hold, same kind of a thing. My index fingers in the suboccipital area, eminence on the zygoma, parietal, temporal area here. Cup the ear. You don't want to kind of squish it out and be like that. You kind of can cup it. You want to have this hand is ulnar deviated so that I can, have control of her head. Also, as I mentioned before, you want to have your hand just rest on the table because then she feels like her head is stable. Because if I hold her up to do this, eventually she's going to feel like her head's in space. She's going to tighten up in reaction and in response to that. So then I'm going to find C1. This is the lever for this correction for occiput C1. My line of drive, again, is like this, and you can see that I'm behind my thrusting hand. So I would take the slack out, and then when the person's relaxed, make a correction. Now, when I do that, I'm not going to kind of whip her head this way. I'm not going to take this hand and whip her head that way. It's the thrust hand that makes the correction. But remember, and this is the same, and even more so for the entirety of the cervical spine, when I push her like that, her head goes into extension. So it's really not this hand whipping her head back. It's this hand pushing it, and this hand receiving it. Because remember, both hands act in concert. They are both actively engaged, although one is the thrust hand and one is the indifferent or receiving hand. Okay? And so, just so you can see it on this side, on opposite sides, let's just say that the lesion was on the right-hand side. This is the jam side, okay? And then if we're going to use if we're going to use C1 as our lever, then the lesion side is down. My hand is going to contact the upside C1. Take my slack out, slack is to the throat, and then make my correction that way, standing behind my thrust. It's on C1. Yeah, it's always on C1.
It's going straight across.
Yeah.
Lesion side.
So you're under the C1. Okay.
Right.
The other time.
So that's occiput C1 using C1 as a
Instead
lever.
of going straight across, you're going
Now, just in terms to incorporate what we learned last week, if we're doing C1, C2 as a complex, so we're going to use C1 as the lever for a problem at that level, and we're not doing occiput now, occiput C1, and this just looks like what we learned last week. The lesion's on the right side is up, it's the same thing. And then C2 would be the same thing, same three, it would all be the same except my line of drive would be changing a little bit depending upon how that was. So you all understand that? It's only occiput C1 that has the lesion side down, or where you're kind of contacting it opposite. All right. So the other contact, or the other lever, is the occiput of occiput C1, right? So we just showed you how to correct it using C1. Now I'm going to show you how to correct it using the occiput. Now this one looks very different and also uses what's called the chin hold. So when you use the chin hold, you have to be very careful because you kind of have your hand on somebody's jaw so you don't jack up their TMJ. So let's say the problem is on Dr. Marie's right-hand side. So what I'm going to do is I'm going to kind of lift up her head, so I'm just kind of supporting it with my hand underneath it. I'm going to reach around, grab her chin, and rotate her head. And then when she's rotated, my forearm is in the suboccipital area. It's not like laying across her ear or up here. It's in that suboccipital area because that gives me that ledge, right? That contact point. My other hand is going to come again in that L. My thumb is going to be in the suboccipital region. Try to get your earring out of the way so I don't pull it out. And my index finger comes across the parietal zygoma. You all see that? And my forearm is parallel to her sternum. So the side that's down is the jam side, right? So that what I'm going to do is now I'm going to lift her head up. So I'm going to, I guess, kink it up, right? So I'm just opening up C1 occiput, as opposed to lifting her head up like that. I'm not lifting up the entire head or spine. I'm just lifting up her head to kind of make that at C1 occiput. You have to be careful when your hands are in contact. You don't pick their nose or get your fingers in their mouth or poke their eyes out like that. And you don't also want to hold your fingers down here in their throat and choke them out either. So most of my pressure is index finger and thumb and my forearm. So these fingers aren't really doing anything. I can still do the correction without them on the patient. But it's kind of stupid to have them out like that. So they're just kind of holding the patient. Slack up, slack out, and then just make my thrust in the vertebral axis. So it sounds easy enough to say I try to pull her head off.
Oh, okay.
But the jam side is
yes, the
down,
jam
right?
side is down.
Just pulling it up.
So what this looks like. I'm gonna hold this one. No, don't worry about it. I'm going to do the other side. So the problem was on this side, right? She's jammed. I'm going to reach around and then rotate her this way. This hand's going to come up here. This underneath hand is on that suboccipital ridge. And then when I kink her head up, what I'm going to do is this. So you see how that opens up what was the jam. And then I'm going to follow the vertebral axis so that when I make my thrust, I'm just following her spine. Like that. Now, and I'll do it on the other side so you can see it on the other side.